Hello, everyone. Hi. I think it's a little blurry here. Let me clean it off a little bit. Hi, everyone. It's Yvette McQueen, MD. Hey. Yvette McQueen, MD. So I'm live today. Usually I'm Monday. This is Thoughts of an Emergency Doctor. And usually I'm doing this Mondays afternoon at 3 o'clock p.m. But today I decided to postpone it because of the solar eclipse. Many people were finishing up, returning to their offices and other places after viewing the solar eclipse. So I wanted to postpone it a little bit and give people time to get back together. So this is Thoughts of Emergency Doctor. I'm Yvette McQueen, MD, emergency physician and travel doc. So emergency doctor, physician, and travel doc, a global physician on a mission to educate about health, travel wellness, and disease prevention. And I've been telling you about thoughts of an emergency physician. So I don't see anybody live with me, but I've been recording it and gotten some feedback, and I appreciate that a lot. This is, get my little cheat sheet here, okay? Let's see. So last week I worked 4 days last week. I'm not sitting right. I've been told I need to sit right. Okay. So last week I worked 4 days. And it was interesting. I don't know if the solar eclipse was making people strange. I don't know. You know, with the emergency room, sometimes we say that the full moon affects people, and it does. It really does. It affects people. A lot of babies are born then. We do know that, so it does affect people. And maybe the solar eclipse affected people. It maybe did. So I was working last week, and things that just made me say, people should know what's going on. So one of the things I want to talk about, when you come to the emergency room and you're telling the doctor what's wrong, and they say, what's wrong, why you're here, what's going on, and you start to tell them the signs and symptoms that made you come to the emergency room. Now, I've said this a couple other times. Do not lie. Please don't lie to your doctor. It's very helpful for us to know the truth. But particularly if it's something that's been going on, this has been going on for the last year. This has been going on for the last 3 months, and you're in the emergency room. And I like to tell people the emergency room, emergency department, is for things that's going to kill you in the next 72 hours. That's my job, to make sure you don't die. That's my job. So when people start to tell me, this has been going on for 6 months, my next question is going to be, what is different today? So if it is different, and there had to be something that you finally gave up and said, enough is enough. Did the pain get worse? Did it change? Something. So it's always good to know what made you finally say, we're going to the ER tonight, right now, particularly if it's in the morning, like 3 or 4 o'clock in the morning, and you say, okay, I need to go now. That's what we want to know. What triggered you to say, let's go? And so you'll tell me things, but sometimes it's not so much that the patients are lying, but they just kind of forget information or omit it. And it's important that we know what that is. Like, let's lead off with, by the way, I have such and such cancer. That would be helpful. Because you know what, the doctor, even though you may have told the triage nurse or the nurse that checked you in It's not necessarily the doctor did not read the chart. Sometimes we choose not to read the chart so much because we don't want to be biased. We don't want someone else's opinion to offshoot us and think one thing. So sometimes I go in a room and I've looked at the vital signs, but I don't look at the full detail because I want the patient to tell me. But it's good to know, like, again, oh, by the way, I'm pregnant. Or, oh, yeah, by the way, I just had heart surgery. Yeah, let's lead off with that stuff first, the major stuff, to tell me. And that gives me a point of reference of where I'm going with everything else. Okay? So that's one of the things I thought about. Another thing, so in the emergency room, when you come in, we're doing lab tests, we're doing x-rays, and whatever's going on, we may fix you, make you feel better, everything's okay, and then you're like, okay, now I'm ready to go. It doesn't happen that fast. Okay, I figured it out, or I'll say, okay, your problem is such and such. And you go, oh, I'm glad I know now. Let's go. It doesn't happen that much. Unfortunately, we do have to have paperwork. I do have to have a chart, and it's preferable if I do the chart right then and there when you're there. Because then I look at things, I look at your medicine, compare things, give advice. I have to put down discharge instructions. If you've been there for more than an hour, the nurse has to take vital signs again, and they have to do their discharge planning. So don't say, just because I'm leaving the room and say, okay, I'm gonna send you home, now you're like ready to go. But it's just not that fast. And you standing in the door looking at us does not make us move faster. It really doesn't. That's actually kind of irritating because we feel like we're being watched and put under a microscope. And if you're waiting for your x-rays or something to happen, you standing in the door does not make it get done faster. Or you're like, well, you guys are just standing there laughing and talking. When we go and order something, we put the order in a computer, and sometimes it takes it to process. Good. Okay, I'm reconnected. Wow, that was a little blip there. So I'll order something for pain. And then the nurse has to, receive it on her computer end, and it has to transfer. So it goes in the computer, it goes to the pharmacy filters it where and say, yes, there's no allergies or contraindications for this patient taking this medicine, and then send this to the nurse's computer. Sometimes as swift as a minute. Sometimes it takes about 5 minutes to transfer. And then the nurse has to get it out and account for the medication and to bring it to you. So it doesn't happen swift like magically either. So, and you standing in the doorway saying, where is it, where is it, where is it, does not help us. Second of all, because of HIPAA laws, I talked about it before, Privacy Act. HIPAA is the federal privacy act that states I cannot discuss someone else's condition with you without their permission. So because of HIPAA laws, you do need to stay inside your room and not just in the doorway, because there's occasionally, if we're standing at the nurse's station or walking down a hallway in the emergency room, not regular hallways or elevators, we're just still in the emergency room, patient's information is discussed. Like, can you go get that patient in room 3 to do X, Y, and Z, blah, 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 blah. And if you stand in a hallway, you're actually hearing the information. And that's, not deliberately, but we try to abide by the HIPAA laws as much as possible. So please don't stand in the doorway with your arms crossed, looking at us, think we're just laughing and up, not taking care of you, because we are. We've placed orders. We're waiting for things to happen, and it does take time. It's just not a poof, it's done. We wish it was too, because then we could sit around and talk. Let's see, eating in the emergency department. So this is a big thing. People come there and then they get in their room, we take care of them, we start an IV, draw some blood work, and they're like, can I eat? No. Especially if you came for abdominal pain. You're saying, oh, I came for abdominal pain and I was throwing up earlier, but can I eat? Because now I'm hungry. Well, no, because we need to figure out what's going on. Or you come for, say, shoulder, hip, arm, whatever the wrong is, and you say, well, can I eat? No, because I don't know if you're going to have surgery. Well, it may not be tonight. It may not. But if we find something that's wrong and we have to call the surgeon, the first question the surgeon is going to ask is, when was the last time they ate? Because if I can take them to the OR right now, it'll be great. And then I'm like, no, we actually just fed them, sorry. So your surgery is delayed and maybe your condition is delayed. Why is that? Because anesthesiology, the people that put you to sleep during your surgeries, will prefer you have not eaten within 6 hours. Because when we give you medications to sedate you, make you sleepy, and occasionally we do put a tube down your throat to help you breathe during your surgery, all of that can increase your risk to throw up, and then the contents go into your lungs, and then you get pneumonia. And our first goal is physician do no harm. So that's why we state and tell people, no, you can't eat, because we don't know what course you're going through. Also, there's certain tests that we don't want you to eat because it alters your test. If I'm checking out your gallbladder, you should not eat. If I'm doing a CAT scan of your chest, you should not eat, because that affects your vessels and esophagus and other things that go down the middle of your chest. So no. So when you come to the emergency room, and no, you can't eat. And now if we say, oh, you're finally admitted, you're going upstairs, and we'll consider you eating, especially if you're not going to have any procedure that night. But while we're still evaluating you in the emergency room, no, you cannot eat. So that's a question we get all the time. And I go, really? You just told me you were throwing up. So no, I'm not going to give you food for you to keep throwing up. Now at the end, I may give you something to drink or something like that to make sure you're not throwing up, or if I need to give you more medicine. Okay, so yeah. Another case. As any job these days, we are dealing with staff shortages. We just are. Whether it's physician shortage, yes, there's a physician shortage. Yes, there's a physician shortage. Actually, they say come 2030, which isn't that far away, that's less than 15 years, they said there's going to be 60,000. Do you hear me? 60003, four zeros after 6. 60,000 physician shortage. You're going to have a hard time finding a physician. So that's definitely going to affect the millennials. So that coming up, there's going to be a physician shortage. But we are dealing with physician shortage and nursing shortage right now, particularly in the emergency department. It's usually in the ER we have trained nurses. They're usually not fresh out of nursing school, so they're seasoned trained nurses, because they have to have some awareness of patients' conditions, whether they're sick or not sick. And that's also a shortage of the seasoned, experienced nurses. So we do have nursing shortage. So we may be working short. So if the physician, say you're in an emergency department where there's 15 beds and I only have 2 or 3 nurses, those nurses are working hard. One is always triaging, one is managing, one is seeing the patients, one is getting the meds. So if things aren't done right away, just know that you are not our only patient. We are juggling multiple patients, and we will take care of the patients that we educatedly feel that we are trained to triage those that are going to die first. We take care of them first. So it's not saying we're lessening your pain. I talked about triage and different levels and different areas of the emergency room you can go to. We're not lessening your emergency. But someone that's had back pain for a few months and it may start acting up, unfortunately will not be seen before someone that's not breathing. That's just reality. So we're going to take care of those that's dying first, and then go in a certain order. It's not in the order that you show up. So you should know that. But we are juggling multiple patients at that time. Let's see, what other things that make you go, oh. You know, when I'm examining you and I see you and I put the stethoscope in my ears and on your chest, I can't hear you. If I have the stethoscope in my ears and you keep talking, I've missed that conversation. I can't hear you. I can't. So unless I took the stethoscope and put it up to your mouth. But if I'm listening to your lungs and heart and stomach and you're talking, I did not hear what you said. And I may have heard that you're actually speaking, and afterwards I'll say, please repeat it. But I can't hear you if I have a stethoscope in my ears. I just can't. That's because they're fit nicely so that we can hit those faint sounds, particularly the heart. So if your doctors listen to your heart and lungs, please don't talk, because it just, one, messes up with them hearing the actual lungs and heart and stomach, but they can't hear your conversation either. Okay, so I talked about when I'm going to be seen. You know, make sure you're not lying to your doctor. Tell them why you're there, what triggered for you to come to the ER at that present moment. Lead off with the bad stuff. Lead off with the stuff that you know is really wrong with you, your medical history. And if I see you and you say, oh, you know, by the way, I do have congestive heart failure. Yeah, that's helpful if you're having chest pain and leg pain and swelling. No, you can't eat in an emergency room if we're still evaluating you and doing tests, particularly if you came for abdominal pain and vomiting. It takes time to fix you. And just because we're finished then and we can't rush off, we do need to do our records. We do need to send information from one computer to the other or the pharmacy, or get that sling for you that we need. No, we're not just standing around talking about our events. We may be waiting for something to show up in the tube system. So sometimes when we're getting things from the pharmacy or other places, they actually have to send it to the emergency department. We don't keep it right there. And let's see, there's a staffing shortage. Okay. And remember, don't abuse your healthcare workers. You know, a lot of times out there now, people feel that they can abuse us. And we're there for you. We're trained to help you. We want to help you. You came to us for help. Please do not abuse us and disrespect us. We understand there's some conditions where people can be a little unstable, and we accept that, but don't be angry with us because we couldn't solve your problem, because sometimes we can't. Don't be angry because things didn't occur the way you thought they would occur and decide to disrespect us and abuse us, because we are there to help you. And that's why we show up to work every day or every other day or whenever we show up on our shift. So that's how I'm going to end right now. So no one joined me tonight, but that's okay, because you can catch this wonderful thoughts of an emergency physician, thoughts of an emergency doc, things that make me say, Hmm. So I'm off to work in a couple days, and I may come up with a few more things that that patients should know. How the emergency room works, what the emergency doctor is thinking. That's why I'm here to discuss it. Or I may pick another issue. You know, another disease out there that's going on. I may think about that and see what's going on in the world this week. So this is Yvette McQueen, MD, a global physician on a mission to educate about health, travel wellness, and disease prevention. You can find me on all the social media at Yvette McQueen MD, along with being on YvetteMcQueenMD.com. That's YvetteMcQueenMD. So enjoy your week. See you next Monday, and ciao.